exactly the same TIs for the follow-up, the institutionalization survey. But as I'll explain later, there was quite a lot of lumping and splitting going on. So some TIs got split up into more than one to respond to government guidelines. Sometimes TIs were merged, so it was actually difficult to trace them all. And we ended up with a slightly smaller sample for the institutionalization survey. For the case studies, we did longitudinal case studies of 16 TIs, and we selected them to try and get a lot of variation across states, across key populations. And we did these about 6 months after they had transitioned. So whilst the memory of transition was still fresh in their mind, they also had some experience of what it was like working in the new environment. It was really like a sort of 360-degree set of interviews, talking to the managers, talking to focus group discussions with the key populations, and then interviews with the state-level people as well about these specific TIs. And then we also revisited a subsample of them, 5 TIs, 1 to 3 years later. So we had snapshots of what went on just after transition, 6 months after, and then where they were at, 1 to 3 years later. So the first sort of part of the findings is really around what was the transition strategy and how was it implemented. And these were the main components of the transition strategy, which were fairly consistently reflected. It was to do with strengthening government systems, both at the national level, state level, and local level. And I think you've heard quite a lot of that already described, both by Matangi and Dr. Dhingra. It was also to do with building capacity amongst the NGOs and the community-based organizations that were actually responsible for running the TIs. And at the same time, and I think in the end this took up an awful lot of effort, aligning both clinical and non-clinical aspects of the programs with government systems and government norms, as well as enhancing key populations' capacity to demand access to services and information. And finally, and not insignificantly, around promoting government commitment to targeted prevention programs. I would note, however, that this transition strategy was continuously evolving. So if you look at the sort of 2007 documents that articulate what the transition strategy was, and then look at more recent documents, you'll find there's different elements and different emphases. So it had to adapt over time. The elements that I'm going to focus on most in this presentation are around these 3 central elements. So our focus for the evaluation was primarily at the TI level. We did also do some work around point 5 here in terms of looking at government's overall commitment to transitioning and to retaining the focus on targeted prevention programs. But most of what I'm going to speak about today is around the transition of the TI programs, what went on in terms of capacity building, alignment, and enhancing key populations capacity. And I wanted to start out with an overview, and I think you've heard this already, but in our view, the first tranche that took place in 2009, the small tranche, was problematic for a number of reasons. It happened in a really short time frame. Often preparations for the transition that occurred in April only began around sort of January. They were often still negotiating which TIs would transition just a few months before the transition took place. There was a lack of collaboration between the government and the Avahan actors, sometimes quite a lot of mistrust between those 2 actors in terms of what their intentions were and what they were trying to do. And then there were substantial delays after the transition took place in terms of getting new contracts set up, getting funding and supplies flowing. And there was limited post-transition support. I think often Avahan and the state league partners had assumed that they'd be able to provide post-transition support. In practice, that wasn't always the case. One state said, we really don't want you messing anymore with these TIs that we are now running. The second tranche actually was 2 years later, so there was a 24-month period for learning, reflection, and being able to improve things. It was a much improved round, but it was also a very small round. It was only 20% of the total. We observed strengthened relationships between Avahan and government. There were transition manager posts created, both at the state league partners and on the Avahan side, and there was a much longer period for preparation. They also recognized that there might likely be delays in terms of getting stocks and commodities moving, funding moving, and so buffer stocks were created, and there was a move towards clearer agreements around post-transition support. I think the big question in 2012 then was, well, 2011 was successful, but it was only, 34, something like that, TIs that were transitioning. are you going to be able to do this for the much larger numbers that were transitioning in 2012? Our sense again is that there was even earlier preparation, often starting about 9 months before transition took place, in terms of building the skills, aligning the systems, very strong collaborations at the state level by this point. And the process was guided by a common minimum package for transition. So it's just a spreadsheet that lays out in quite a lot of detail what needs to be done on multiple different dimensions to allow transition to occur at the TI level. And the post-transition support agreements were institutionalized across all of the TIs, so very clear what kind of support the Avahan team could provide afterwards. So I'm going to go into just a little bit more detail about these different dimensions. We were interested in capacity building and engagement. To what extent was capacity really built in advance of the transition, and were the NGOs prepared? We saw improved staff training on transition over time. Both TI managers and staff received more training in 2012 than they had received in 2011, although we did observe that that training continued to be focused more amongst the higher level staff than the lower level staff. And we also noted that 2012, some of that training really came pretty late. There was also a plan to involve staff within the TIs in preparing for the transition and in preparing transition plans. That happened to varying degrees with big differences between states. We looked at both clinical alignment and non-clinical, meaning sort of managerial, financial alignment. In terms of clinical alignment, largely what was going on was a shift in service delivery away from the services being provided within the TIs to much greater reliance on government systems and government health services for the provision of services. And that meant that by and large, providers were less regularly available and less easily accessible to the key populations. But at the same time, there was quite a lot of sensitization work that took place on the government side, preparing the government systems to accept more of the key populations into government clinics. And we heard that reflected from the key populations, that they felt that in terms of seeking care from government, there had been improvements in terms of stigma and discrimination that had previously been felt. However, the key populations also talked about a shift going on from a model whereby Avahan TIs had provided fairly broad health services support for STIs to a system that was much more focused narrowly on HIV testing and referrals. We found on the sort of specific indicators of clinical alignment fairly high levels of clinical alignment across STI syndromic management guidelines, for example, which were different between Avahan and government, as well as referral rates to government integrated counselling and testing services. And I think that this chart reflects that. These were the percentage of TIs in the 2011 round, 2012 round, which were fully aligned with government norms in these respects when we did the survey just before transition. And then as I'm about to move into the non-clinical alignment, these were the data coming from on the non-clinical side. And you'll see that by and large, they were fairly well aligned, the exception being really around procurement. And the explanation for that was, well, was because of the buffer stocks, because they recognized that there might well be delays in terms of getting new contracts in place and getting commodities flowing through the government system. The Avahan teams had built up buffer stocks for commodities, which meant that the TIs hadn't had to fully shift over to government procurement systems at the time that we did the surveys. Is this all making sense, more or less? I'm going fairly speedily, but maybe save questions till later, because otherwise I don't think we'll ever get through it. But, non-clinical alignment. As I've already said, we saw high alignment of budgets, TI team structures, reporting systems. Many TIs described having to cut salaries, and some also cut staff. Some TIs also noted that the budgets, the limitations on budget had meant that they had to cut trainings, meeting, traveller allowances, outreach, office expenditures. Although there were substantial cuts being made, I would say that from the programme manager's perspective, by and large, these weren't disastrous. They were manageable. They were uncomfortable, but manageable. The other thing which I'd already alluded to was at the time of transition, there was quite a lot of splitting and merging of TIs going on, and that really contributed to the stress of the process. So Avahan TIs would often have men who have sex with men along with commercial sex workers in the same TI group, Often they were split out at the time of transition, and also there were changes to TIs just to make sure that they were more standardized in terms of the numbers of key populations that they were covering. I think the other big set of issues that arose in terms of non-clinical aspects of alignment was around peer educators and their role post-transition. Travel allowances were reduced or frozen post-transition. That made it harder for the peer educators to get around the districts. There was also an increase in the number of KPs that peer educators were meant to be serving almost everywhere, although some state league partners managed to negotiate some exceptions there. And there are also new literacy requirements on the government side, which basically required literacy amongst peer educators, which Avahan hadn't required. It seems like a small detail, but obviously had quite significant implications in terms of program management. The final element that we looked at in terms of transition readiness was around enhancing key populations and capacity. And I would say overall the perspectives that we got from transition from the targeted intervention program managers was rosier than the feedback that we got from the community members. Community members expressed more negative views about the effects of transition on community mobilization and outreach, and they felt overall that there had been a shift away from providing incentives and community recognition activities to a sort of narrower focus on HIV/AIDS prevention. So even small things like the discontinuation of funding for tea and refreshments, it was very small budget line, but it was taken away, there was much more limited budget post-transition to accommodate this, and the key populations were concerned about the discontinuation of these such services. And I talked already a little bit about the shift in clinical services and the fact that there were some mixed feelings amongst the KPs around this. On the one hand, some felt appreciative that they were being mainstreamed in government clinics, but they also mourned the loss of general health services provided by the targeted interventions. And I think it also played out very differently for different key population groups. The groups such as commercial sex workers who could blend in more easily in government clinics were less concerned about this than, for example, transgender groups. In terms of the second question about how well institutionalized were the key features of Avahan after transition, we went about addressing this question by using a Delphi technique, which is basically sort of circling around a group of key informants to figure out what are the key elements of Avahan that you really want to persist after transition has taken place. So we worked with a group of about 20 key informants, both BMGF staff, but also other partners within the Avahan program. And they identified a set of key features of Avahan that they thought were really critical that these persisted post-Avahan. I've reflected them here and sort of also bundled them by a set of, according to a set of management practices that people thought were key, extensive use of data, strong on-site supervision, things like that. Around funding and supplies, they were very focused on the need for on-time, adequate, and uninterrupted flow of funding, and then a set of roles around peer educator roles, which they felt were very important. So in the institutionalization survey, we asked the managers of the targeted interventions about the extent to which these practices had continued and whether they had stayed the same or not. In terms of the management practices, what we found was that there was actually a significant amount of change had taken place in the programs in a very short space of time, in the sort of 9 to 12 months after when we went back to do this survey. So you can see this here, both for the 2011 cohort and the 2012. So 60 to 75% of them saying, on this indicator, supervision has changed. But then what was surprising was that the large majority of them, and this applied for all elements of management with the exception of one, was that they felt things had changed for the better in the 9 to 12 months after transition. And this was the explanation that they provided. Supervision is more regular, we have monthly video calls with the project director at SACS, supervisors spend more time in the field, and while there were some negative views expressed, overwhelmingly the sense was that things have actually got better. The one exception in terms of management practices was that SACS and the state aid control societies were less flexible than Avahan, which I didn't think was a surprising finding in many senses. In terms of institutionalization and funding and supplies and the extent to which there were uninterrupted and adequate funding and supplies. I think the picture here was more mixed. Close to 70% of the TIs said that they normally had sufficient stocks of commodities. They noted commodity stockouts, particularly for condoms. In terms of cash flow, 7 to 14% of the TIs across the different rounds said that they regularly had problems with cash flows, and only 40 to 50% said that they have never had cash flow problems. Although you could say that delays in disbursements were not extensive, 15 days to 1.5 months. I've already pointed out that the transition led to lower budgets and some of the consequences of that. The third element that we looked at in terms of institutionalization was around sort of peer educator roles. And again, I think you can see from this that there were quite substantial changes that occurred in terms of peer educator roles. But often people felt this was for the better. This wasn't actually entirely true for training, where people said that budgets for training have been reduced, although some thought that this had been compensated by the fact that training was actually better targeted now than it had been under Avahan. So the sort of third section of the results were to what extent were the sort of service coverage outcomes that were established under Avahan sustained post-transition. And you've already seen some slides from Matangi that address this. We looked, and this data comes from the TIs that we surveyed, we looked at the percentage of high-risk groups contacted per month by PEs. And as you can see, the picture is fairly similar to what Matangi was suggesting, that there was not much change pre and post-transition. We've actually combined the data from both the 2011 cohort and the 2012 cohort here. And in terms of number of condoms distributed per HRG per month, again, fairly flat trend line. We're not seeing drop-offs in service coverage post-transition. Although I would point out that our data only go up to 9 to 12 months post-transition, and I think that it would be very interesting to go back now, that much later. You'll have realized that we've had data around transition readiness, how well prepared the TIs were, the extent to which key Avahan practices were institutionalized after, and what happened to service coverage. So we were interested in exploring the relationships between these, and I won't go into the technical detail, but just to say that in terms of the effects of transition readiness on service coverage, from the analysis that we've done, there seems to be a very significant effect in terms of those TIs that were better prepared at the time of transition ended up with better service coverage. Less easy to explain was the fact that institutionalization and our measures of institutionalization seem to be insignificant on all roles, so on all fronts. So there's no linkage or correlation between the effect of transition readiness on institutionalization, and institutionalization doesn't appear to have affected service coverage. There's a number of different explanations. It could be that our tool capturing institutionalization just didn't do a very good job. But I think that we also felt that there was some conceptual dissonance there, in the sense that on the one hand we're asking how well aligned are these TIs with government norms, and on the other hand we're saying, well, we want you to align with government norms, but we also want you to adhere to some of the key features of Avahan. So there's sort of tension there that I don't think we fully worked through on our own. I'd also point to the fact that it was clear that a lot changed immediately, or quite shortly after the transition. There were a number of changes, but people saw them as being for the better rather than for the worse. So in terms of elements of a successful transition and a few final reflections, I think that the list of sort of key elements that we've got actually reflect fairly closely the points that Matangi put up on her slides earlier. We think that the extended timeline and phased transition, with transition discussions starting 7 years prior to the final transition, were actually critical in terms of making this effective. And the sort of significant period of learning, particularly between the first round and the second round, when there were 24 months, where they could reflect on what worked and what didn't work, was also key. Very substantial investments in TI preparation. We've talked about the transition managers, the clear budget lines to support the transition process, buffer stocks of condoms and supplies, post-transition support agreements, and the common minimum package for transition that really laid out what needed to happen for transition to be effective. In terms of commitment to transition, I haven't talked much about it in this presentation, But we feel that Avahan was very fortunate in terms of being able to transition to a government that at the time expressed a very strong commitment both to the content of the program as well as to taking over the Avahan program post-transition. But I would also say that BMGF signaled fairly clearly up front that they were serious about transition. They signaled it through their memoranda of understanding with government, and they also signaled it by, in a way, stumbling through that first transition round that wasn't very well prepared, and everyone kind of knew that. But it was a signal that we're serious about this. We're going to go ahead with it almost in any case. Development of communication and trust. There was a lot of emphasis on communications. It was relatively strong. It clearly became stronger over time in terms of communication between the multiple different layers and the multiple different actors involved in Avahan. And I think that the extended time frame also allowed development of trust over time. As I said, first round there was some mutual suspicion between actors that evolved into collaborative working relationships. And finally, I think both sides demonstrated an adaptability and a willingness to sort of work with challenges that came along and address them over time. The initial strategy, for example, did not address community mobilization separately. As you've already heard, there have been significant amendments to the transition strategy to be able to take that on better. So just final reflections. I think we came away with the sense that transition is a really dynamic process. You need to plan for it, but you also need to be prepared to adapt as you go forward. It creates adaptations both on the donor side as well as on the government side. I think there is one question here about which adaptations are acceptable to both partners. And I think, if we had hindsight, we would have gone back to the beginning of the evaluation and said, to Avahan and to government, what really matters to you in terms of what happens post-transition? What are the stakes in the ground that you really feel we need to hold on to post-transition? There's so many different moving parts to a program like this, and we were really trying to track them all. Secondly, to acknowledge that transition, programs may have multiple owners. I think Avahan invested a huge amount of energy in terms of ensuring an effective transition to government. The community part of this came in a little bit later, but there may well be other owners of a post-transition program. It would be worthwhile giving them more thought. And then finally, and I think this is sort of very much a high-level overarching lesson, clearly transition presents risks to program sustainability. But I think, and I feel in many respects that the Avahan transition demonstrates this, there are also really significant potential for positive and empowering experiences on both sides. Okay, thank you very much.
Sarah, thank you. And thanks for so much great information in such a condensed form. And I certainly was struck just by the perception and reality issues, not only Avahan, the government, but also the communities that were being served, where their perceptions are sometimes different from the other two. So I think in the interest of time, maybe we'll just hold on any clarifying questions for Sarah. We're going to go right to Rob, and then we are still going to preserve some time for discussion among the group. So Rob.
Thanks very much. Hi, everybody.
Rob, just say a word or two about the bigger set of work you're placing this in, because that's
part of what I was going to say. I'm looking at the clock, and the clock is not my friend. So let me see what I can do. I woke up this morning thinking about this, and my mind was working with the number 4, and you'll understand why in a minute. First thing I want to say of 4 is that I'm really happy to see this event take place. As Lisa said in her opening remarks, this whole process of transition is so important and so hot right now in global health. And within global health, I don't think there's a bigger sub-area than HIV, because so much external financing through the Gates Foundation, through PEPFAR, through the Global Fund, through other sources, has been going into supporting these programs. And the ground is shifting. So how to achieve successful transition in HIV, I think is tremendously important. And within the series that we're doing, this really stands out. And among the HIV transitions that I'm aware of, and I've been looking some at what's going on in the PEPFAR world and a little bit at the Global Fund, is the Avahan experience really stands out. I think in terms of its many positive features, which you've been hearing about over the last hour and a half. So that's my first remark. Secondly, it occurs to me as we get into this question of transition and country graduation, the move towards self-reliance away from external support, that I've been in this development business now for a few decades. As Lisa said, I worked at the World Bank for many, many years, and at UNAIDS I had a wonderful time at an exciting moment in the history of the AIDS movement and elsewhere. And it seems to me we spend an enormous amount of time designing things ex ante. We spend an enormous amount of time on entry, and we don't spend nearly enough time on exit. And as I get a little bit older too, and I get a few gray hairs, I start to realize that maybe exit is going to matter for me too. I start thinking a little bit about finishing strong, and we were always focusing on starting strong and designing major programs, but those programs are ephemeral. They're not there forever, and especially when they're externally supported, there's the challenge of handing over. These countries' economies are growing. India's economy has been booming over the last decade. We hope that'll continue. And the government's capable of investing. The domestic resources are there the way they weren't 10 or 20 years ago. And there's a shift in donor attitudes, if not fiscal realities or some combination. So I just want to make a plea for all of us to be focusing on this question of exit and transition, because I think it's tremendously important. And we've been in this series that Sarah and I have been co-hosting, we've been looking at a number of these examples of these transition challenges, most of which are ongoing today. So I hope you're all going to devote the rest of your careers to this, or at least the next 10 years to this topic, because I personally feel it's very important, and I think it's neglected. When we think about the Avahan transition, I just want to say that my reflection today, it may change, is that I think there are actually several different flavors of transitions going on. We presented the Gavi experience. We talked about family planning transitions in Latin America. We hope to be having a session a month or so from now around the polio eradication program and its transitions, and another one around the Ebola efforts in West Africa and the way in which that's being transitioned or phased from one manifestation or one emanation to another. But I think it's important that we start to see that these transitions are not all the same. Not just that the diseases are different and the countries are different, but I think the nature of the transition is different. So I want to put forward the idea that there are actually 4 different kinds of transitions going on here, and I'll put Avahan in the third or fourth one. First of all, there are some transitions we've been looking at where it's really a question of transferring the financial and at least in the case of Gavi, the sort of narrow procurement responsibility for a particular part of a global health program, but it's already a program which is well nested within the national system, and that's the immunization area, and the challenges of transferring the purchase and the delivery of new vaccines, like the pneumococcal vaccine and the rotavirus vaccine. And Gavi's been very vigorous and I think pretty disciplined, just like the Gates Foundation, in going about that process, and also trying to learn and to adapt. I think there are a lot of similarities in the way in which the transition's been handled, but it's a certain type of transition. These national immunization programs existed before Gavi showed up. These vaccines have always been within these national programs, and Gavi's responsibility has been relatively narrow. It's been around paying for, subsidizing the cost of these new vaccines, seeing that they get out there, and so that's what's being transferred. So I think that's one type of transition. There also are transitions, if you read the literature, which I would call the indigenization of foreign programs or institutions to make them national programs or institutions. And there's a little bit of that in Avahan, I don't deny that, but I'm thinking really here of what we heard in family planning, where we really looked at the question of the IPPF affiliates in a lot of these countries that were getting a lot of external support, financial and even the management, and they were then, when USAID pulled back in the last decade or so, they became national programs, self-sufficient. These national institutions, or these institutions, continued to exist, but the responsibility and the funding moved from external to internal. So I think that, and I think there's somebody here from PSI, right? I think the question of what's going on with the indigenization of your social marketing affiliates is exactly or very similar to what I'm talking about in the family planning space. And the social marketing transitions are also a very interesting topic, which we haven't